You may have already joined me in my other videos about secrets of breast cancer surgery from a breast surgeon. Here, I will share what may not be commonly mentioned on social media or highlighted by breast surgeons during consultations with their patients. In this video, I will discuss the issue of breast dents. What are breast dents? Join me in this video to find out. Also, at the end of the video, I will place illustrations of surgical results next to each other to allow direct comparison of the outcomes with different techniques used. This has not been done before, so you may wish to stay until the end of the video to learn this secret. But first, to put the issue of breast dents in context, I will now discuss the options for the surgical treatment of breast cancer. These can be classified into two broad groups. The first of these is breast conservation treatment. This involves the complete removal of the cancer with a rim of uninvolved breast tissue all around, usually followed by radiation treatment to the retained breast. The operation for breast conservation treatment may be referred to in many terms: breast conserving surgery, lumpectomy, wide excision, segmental mastectomy, or partial mastectomy. The other group of operations involve mastectomy, which is the surgical removal of the breast. Women may elect to undergo reconstruction after. So you may ask, why is there the issue of breast dents? Will it not be solved by a mastectomy? To address this, we need to delve a little into the history of breast cancer surgery. Due to the research evidence available at that time, in 1991, the National Institute of Health issued this statement declaring that breast conservation was the preferred modality of treatment as it provided survival rates equivalent to those of total mastectomy while preserving the breast. More than 30 years later, an expert panel that convened at the 2025 edition of the St. Gallen International Breast Cancer Conference still believed that patients with early breast cancer should be advised that breast-conserving surgery and radiation therapy is usually the best treatment option with comparable or superior cancer control results, less morbidity, fewer complications, and favorable patient-reported outcomes. So breast conservation treatment is an integral part of breast cancer therapy. There are, however, potential problems when breast conservation treatment is administered. If care is not taken during surgery, there may be resultant dents or residual deformity, the term that Professor Beldam used in this 2002 article. So the problem of breast dents has been known for more than 2 decades, and approximately 30% of women who undergo breast conservation treatment have some distortion of the breast shape, which may require surgical correction. What do these dents or deformities look like? These are illustrations of how distortion or dents may appear after breast conservation treatment in the upper outer quadrant of the breast. As Professor Beldam stated, optimum treatment should be preventive, and immediate remodeling of the breast should be performed at the same time as cancer removal. Certain plastic surgical techniques were introduced and integrated with the original operation to reduce the need for delayed secondary procedures. Such strategies are referred to as oncoplastic breast surgery. Personally, I perform what I term as restorative surgery rather than oncoplastic surgery. That said, I shall discuss some techniques classified as oncoplastic surgery, and at the end of the video, juxtapose them or lay them side by side with the results of restorative surgery. This has not been done before, and I believe it will benefit women who may be making a choice about breast cancer surgery. In the section of the breast, which is medically termed as the upper outer quadrant, several surgeons have described various techniques to fulfill what Professor Beldam proposed. One such technique was described here by this group of surgeons from France. The technique used is termed a racket mammoplasty, named after the shape of the incision. At the end of the procedure, you will notice that there is a significant loss of tissue, resulting in the operated breast being smaller than the non-affected breast. Therefore, a recommendation for contralateral symmetrization was made by the attending surgeon. This refers to a separate operation on the other uninvolved breast for volume reduction, so that the sizes of both breasts will be equalized. This team of surgeons from Nottingham in the United Kingdom described another oncoplastic technique. This involves the use of a perforator flap. A large area of tissue is moved from the patient's side and back and modified to form a flap, which is used to fill the space created after the cancer is removed, together with a rim of uninvolved breast tissue. The size of the incision made is as illustrated by the black elliptical markings. After surgery, this is the scar that a patient can expect. The last two articles were published in 2010 and 2015, respectively. What about in 2026? Are the same surgical techniques still being used? The answer is yes. Very similar techniques are still being used, as we see in this article. This team of surgeons from Germany also used a perforator flap, an operative approach they described in 2026. These are selected aspects of the cosmetic appearance after radiotherapy. The scars are indicated by the arrows. The reference to this article is provided here as well, and please feel free to refer to it for the whole series of pictures which the authors present. Apart from these techniques presented, there are several other surgical approaches which are used by other surgeons. I use different techniques, which I refer to as restorative surgery. In cases where cancer is in the upper outer quadrant, I do not use racket incisions, nor do I use a flap. Surgery is planned such that the cancer is removed and the shape of the breast is restored using only the non-involved, healthy breast tissue. Here are examples of the cosmetic results of restorative surgery after completion of treatment. If you wish to have more details on how this is done, kindly submit a request through the link in the description below. Next, I will place the reported results of racket mammoplasty and the use of a perforator flap together with those of restorative surgery. In doing so, you will now have insight into what previously only surgeons would see and know. You can then compare the cosmetic appearance of these three operative approaches and would be better informed about surgical treatment options. As we have already seen, racket mammoplasty is an oncoplastic breast surgery technique that may require another operation known as contralateral symmetrization to equalize breast size. A perforator flap, which replaces the breast volume after cancer removal, results in a scar extending from the base of the breast to the patient's back. These are the cosmetic outcomes and scars associated with restorative surgery. Needless to say, restorative surgery does not involve a separate operation on the healthy breast, nor does it move tissue from outside the breast. In my experience, in about 85% of patients, restorative surgery will suffice to prevent deformity. In this video, we have discussed variations of surgical approaches for cancers in the upper outer quadrant. There are 4 other sectors of the breast where surgeons use different approaches, and I will be presenting some of these in other videos. I hope you will join me in those as well. Thank you for staying until the end of this video. If you have found the information useful, kindly like, share, comment, and subscribe, as it will help me produce videos that reach women who need them. Until we come together again, take care